making diagnosis, providing care, providing medical treatment is again actually with the help of collaborative approach. So once actually we have this all thing, then we will be able to, we will be in position to provide best of the care, and that is what actually virtual nursing defines for. All you need to know about virtual nursing is this. If you know this, you will be very much sure that actually virtual nursing, how important and significant nowadays. Okay, guiding principles address the quality and safety of the virtual nursing. Now, what are the principles to guide about the virtual nursing? First is safe. Virtual nursing is always safe for every patient who are wanting to utilize this facility. So it is avoiding. Why it is safe is because it doesn't provide any harm. Have you heard any time nurses have provided harm while giving care, provided you are untrained? Okay, सर आपण ट्रेनिंग नसेल, आपण ट्रेनिंग अशा ठिकाणी घेतलं असेल की जिथं आपल्याला जास्त ओरिएंटेशन क्लिनिकली मिळालेलं नाही. बरेचसे कॉलेजेस 27 लागू ॲक्च्युली इन्फेक्शन नाही की बघतो की तिथं क्लिनिकल फॅसिलिटीज सुविधा मिळत नाही. अनफॉर्च्युनेटली आय एम नॉट ॲक्च्युली डिमोरलायझिंग एनिथिंग, बट अनफॉर्च्युनेटली आवर स्टुडंट्स आर नॉट गिविंग अ clinical practice. Even though nowadays the trend has come, doctors doesn't allow nurses to touch, your student nurses to touch the patients. But from where you get the experience? That's the question. So always actually where there is a parent hospital of the organization, that the students are getting best of the practices because they have concern. That is the reason actually this virtual nursing provides safe care without providing any harm to the patient, right? Second is timely. So as we said that actually it is reducing waiting time. So nurses are not there 24/7 we say. So they provide best of the care with the best of the ability and the skill that they have. Here it is again based on the scientific principles. So always it is safe for every patient, those who receive the care. Effective. Why it is so effective is because it is already proved. Nursing process, when we talk about nursing process, it is already proved. Most of the time when we write a diagnosis, there also we write, when I am talking about nursing diagnosis. Whenever we are writing nursing diagnosis, we write evidence for that nursing diagnosis. What is the evidence is actually subjective and objective data on that. And what actually method we are used to diagnose this condition. We write the evidence for that. Not only this, when we write evaluation, there also we write evidence. So that it is based on the scientific principles. And that is the reason actually whatever we do, we are answerable for it. And we know why we have done it. So virtual nursing also stands with the scientific knowledge, based on the scientific knowledge. So that is why it is effective one. Efficient. Why it is so efficient? Because when we take over from the earlier nurses, what we do is actually we see all the instruments, we see that whether it is functioning. Very best example, when we get hangover from earlier shift, what we do is actually we check the balance of कसं चेक करतो आहे का नाही, ब्लेड आहे का नाही, हँडल आहे का नाही, असं चेक करतो. काय करतो? What do we do? We put it and then we check whether actually light is working. Otherwise, when in an emergency where there is a need of doing intubation and that light is not working, what doctor will do? We know actually. We don't have to talk about it. So what is very important is actually whenever we take over or we give handover, we check that everything is working condition. Then only we take handover or receive handover from one another. Otherwise, we send it immediately for repair. Right? Are we doing that? Assist करतो. So our nursing profession is greatest profession. Put our hands together for nursing profession. So the त्यासाठी टाळ्या वाजवल्या. Okay, so that is why actually our care is efficient, and even this actually virtual nursing makes it more efficient for providing care to patients, those who take advantage of it. Equitability. Equitability is actually nothing but providing care to all. All means without considering caste, creed, religion, age, or maybe societal status or educational status of the person, right? श्रीमंत आहे त्याला फक्त केअर दिल्यासारखी, त्याला फक्त बेडशीट दाग न पडलेला, कुठं फाटली न फाटलेली अशी बेडशीट फक्त दिली जातात. असं करतो आपण. we don't do that. We provide equal care to everyone irrespective of which background that person is, right? So equitable. Virtual nursing gives rise to that. Patient centered, it is actually based on the preferences. What is required for the patients? See, very significantly, we say that one care plan doesn't work for everyone. Even the patient is not actually having same diagnosis. Are you there? Are you there? We make a list of nursing diagnosis. Do we use for all the patients same nursing diagnosis, same list, same care plan? We do that. आपल्याकडे एवढा वेळ नाही म्हणून करतो आपण तसं. right? But that doesn't work. Does any doctor actually provide same treatment for every patient, though they are diagnosed as a diabetic patient, hypertensive patient? Do they? No. Why? Because every patient has a different needs and problems, different issues. Yes, medically, whatever actually corrective measures are to be taken is taken care by the medications. Medications we can't change. There is a constraint for that. Medical wise, it is the same for everyone. Okay? Maybe actually alternative medicines are being used, so it becomes different than that of actually traditional one. But same is here. So as per the preference of the patient, need and the values of the patient. Value, nowadays we talk so much about the value-based care. So what is value-based care? What is value-based care? Valuing the existence of the patient. Valuing is actually person's identity. Okay? Human being is important, not the characteristics of that person. So everybody, those who are getting admitted under our care, we should value their existence. तो गरीब आहे म्हणून त्यांना कसे बोलतात हे बऱ्याच वेळा ऍक्च्युअली आपण हॉस्पिटलमध्ये बघतो. इथं बोलतोच नाही हे चांगलं असतं. पण बऱ्याच वेळा बऱ्याच ठिकाणी असं आपण बघतो की थोडंसं इलिटरेट जर व्हिजिटर्स असतील, नातेवाईक असतील, त्यांना जी ट्रीटमेंट मिळते आणि नातेवाईक जे सुखादुखामध्ये आलेले असतात म्हणजे ॲक्च्युली एज्युकेटेड स्वतःला भासवतात असंच मिळतं. ॲक्च्युली त्यांना आपण ॲक्च्युली चांगल्या प्रकारे ट्रीट करतो. या बसा, काय आहे सांगा, हे आहे इथंच, तुमची पेशंटची खूप काळजी, हे सगळ्याला म्हणतो आपण. सो देर इज ऑलवेज प्रॉब्लेम, बट नर्सेस नेव्हर डज दॅट. सो हिअर ॲक्च्युली we provide care based on their preferences, needs, and give value to every individual who gets admitted under our care, right? So virtual nursing works like this actually. Nurse who comes on the television, like how we have seen in the previous presentation, madam was sitting at another country and she was talking, discussing with us, thinking that we are very hungry to hear her. The information which she has provided with taking a lot of tables, she has given actually 10-15 references she has searched from it, thinking that actually it will be useful for everyone of those who are attending. Online also there were actually 42 participants. Yes, we could see that. 42 were there. It means person who takes everything in a typical way that actually it will be useful for everyone. Those who are attending it, useful for them, for their career. So similarly, here the nurses, those who are online, they are giving advice to every patient who requires their inputs. So virtual nursing works in this fashion. What are the benefits of virtual nursing? First, continuous patient monitoring through connected devices. So once actually virtual nursing is being adopted or a virtual nurse is being hired, what happens is actually that nurse remains in touch with the patient wherever patient, whichever area of the state patient is belongs to. So she gets in touch with the patient for every movement, for every need, and every concerns of the patient. So continuous monitoring, medication, adherence, tracking, and reminders. See what happens? Usually, when we actually take a medicine, let us take an example. Throat congestion आहे, आपल्याला डॉक्टरने प्रिस्क्राइब केले, अँटीबायोटिक प्रिस्क्राइब केलं 5 दिवसाचं. काय करतो आपण? पहिला डोस घेतला, पहिल्या दिवशी मॉर्निंग इव्हनिंग एक डोस घेतला, थोडंसं बरं वाटलं. सेकंड डेला आपण डोस घेतला, आणखीन जरा बरं वाटलं. तिसऱ्या दिवशी गेला खोकला. काय करतो आपण? We stop taking medicine. Does that work? Symptom आता रिड्यूस झाले, तर ते पुन्हा रेग्युलर सुरू आहे. मग परत जाऊन आपण मला ॲक्च्युली त्याला खिशातले पैसे देऊन त्याचं पेशंट घ्यायचं आहे, मेडिसिन परत घेऊन घ्यायचं. So what is very essential and important is that the course of prescribed medications need to be completed. Similarly here, medications adherence if it is existing in patient, virtual nurse reminds them, don't do this. Please continue the course, complete the course, and come for the follow-up. So that actually any remaining symptoms can be treated immediately, can be taken into consideration, and will be actually complications can be prevented with that, right? That is the second. Third, symptom assessment and trial recommendation. So whatever the symptom that the patient is facing, virtual nurse because he is every day in touch with the patient. So she knows that what symptoms are existing now, which symptoms are reducing now, and accordingly she advises to them, right? And then accordingly she advises to them that actually whether how seriously they have to take which kind of symptoms, right? So this is how actually virtual nursing helps. Post-discharge follow-up and care plan management. Post-discharge, after the discharge, actually what patient has to take care of, what kind of instructions that the patient has to follow, that all actually is considered here in this plan. Health education and personalized guidance. Health education, of course, actually, at the time of a discharge, we give health education, right? We give health education to everyone, same health education? No, individual wise actually we give them health education that in your situation, in your condition, what you supposed to take care of, how you are supposed to take care of yourself. So health education we plan accordingly, and it becomes very easy for the virtual nurse who tracks the patient. So that is another benefit. Next, quick consultation with the virtual nurses enhances clinical decision making. Quick consultation, nurse is always available, so that consultation becomes quick. Now here again actually this is very good existence, very good availability, very good facility through this because she is available, so the consultation is available, it's her advice is all the time, it is there, dot point. So that is why actually it becomes easy to prevent further complications, easy to actually provide best of the care, best of the consultation, best of the decision making for their situation, it becomes easy. Hospital-aged virtual nurses has reported better outcome of the patient. So wherever there is a use of the virtual nursing, they have done, those hospitals have reported that the outcome of the patients has been improved significantly. Okay? So that is where it is very important. Nurses can adhere to the best practices. Adhere to the best practices which reduces hospital stay. Very, very important thing is that actually because of our nursing care, patients stay has to be reduced. Then that kind of nursing care is considered best of the care. we always say about our nursing care, we provide comprehensive nursing care. Which comprehensive is, we are looking at every aspect of the patient, physical, physiological, psychological, psychosocial, even financial. So how we can reduce the burden, financial burden of the patient, like on that also we try to take into the consideration. फक्त मेडिसिन महागडं देऊन पेशंटला होत असेल तर आपली गरज नाही. पेशंटला बेडसोर झाल्यानंतर बेस्ट ऑफ द मेडिसिन देणं महत्त्वाचं आहे का त्याला बेडसोर न होऊन देणं महत्त्वाचं. पेशंट येतो एका आजाराने आणि घरी जाताना आपल्या कृपेनं बरेच ॲक्च्युअली विजिटर्स घेऊन जातो घरी आणि घरातल्या सगळ्यांना ॲक्च्युअली आपल्याकडून गिफ्ट देऊन टाकतो दिवाळी झालेला होता. Is that actually sensible thing? Certainly it is not. When patient comes to the hospital with this sickness or weaknesses, it should get recovered as early as possible, with the fastest and best of the facility here, which we are able to the patient without getting any nosocomial infection. Okay, are you aware about it? So that is where actually we can consider we provide best of the care. Patient getting admitted in our hospital should not develop bed sore or pressure sores. That is our prime responsibility, I feel. In my time actually, I was in charge supervisor of critical care area. We were having 40 days, 60 days, patients are admitted with critical illness, but we never allowed patients to develop pressure sores. A very simple logic and very simple thing that we have to follow. Turn the patient to early. Do not allow patient to develop pressure sores. We have all the comfort devices. We learn in first year. All comfort devices we know, but it is always good. So if patient develops pressure sore or bed sore, it is absolutely our responsibility. If we do this religiously, I would say, turning the patients too early, patient will never develop pressure sore. That is for sure. And that is the reason actually if we do it, then actually it becomes best practices of nurses who provide care to the patient. Eliminating travel time, we have discussed about it. Patient has to travel from all the way from rural to the urban area. Maybe it is very hard for that patient to travel because there are no transport facilities even today in some of the rural areas, unfortunately, which is changing now. But then still, there are certain areas where there is no transport facility of state, and then that is why actually we should not allow patients. Rather, virtual nursing or virtual nurses doesn't allow them to travel all the way for getting even simplest advice from visiting, actually physician or consult doctors, they don't allow them. So problem is sorted out there itself. Accessibility of the visual nursing helps patients to feel engaged in their care. So they are advised and they are advised to take how to care for themselves. This is very, very important thing. If you do everything, then actually that becomes a problem. I will give one example to make you more comfortable with this. In one of the rural area, one of the foreigners visited the rural area, and there actually she found that children are not taken care properly. The personal hygiene was not taken care properly by mothers. Now what she has done? Are you there? Are you there? I think some of them are not there. I'll just give me some time. I'll finish. I was giving one example that foreigner visited one of the rural area. She found that actually children are not taken care properly by the mothers. Those who are illiterate, of course, they were living in the rural area, so children are not taken care that way. So what that foreigner did, she took all the children, she gave a nice bath to them, she brought some powder and all that actually, nice clothes for these babies. She done all everything for them. And after 15 days again she went there, so how they have done it, what they have done. Again children were in the same medical condition. And the foreigner asked the mothers, I thought you actually want to take care of your children, why you did not do? gives back to the children, and that is why we did not bother. So that is how if it is there, then that becomes ultimate problem for everyone. So this should not happen. Here, to feel engaged, get involved into their process, caring for themselves, it gives more weightage to them. They become more comfortable when they are involved in their own care. Like we do in the hospital as well, by giving DT feed, if patient is put on DT feed, we teach to the relatives how to give DT feed. Yes? If not in the ICU, in the medical section, where the patient has to travel with the NGT to the home, so we have to teach them. This becomes our responsibility, right? So once they know actually how to give it, how to check whether the tool is in place, if we teach them, then the consequences will be avoided, right? So we do that in the right way. Similarly, if you are engaging your patient and their relatives, they will be more happy to engage them in their own care. Okay, virtual nursing reduces workload and stress of the bedside nurses. So virtual nurses, what they do is actually doesn't allow everyone to rush to the hospital, and they actually, since they are giving advice one-to-one, so patients are not coming every day for now and then for their simplest complaints or maybe inquiries. So what happens with that? It's on the side. Bedside nurses gets more time to focus on the critical patients, right? So that is where virtual nursing helps to take care of these nurses, reducing their stress and the bedside working. It helps to develop the better working condition because how it improves? It improves the nurses' retention and the recruitment. If virtual nursing is there, then the stress of the nurses who are working at bedside in the hospital is already reduced. So the virtual nursing, the recruitment, and actually their retention becomes easy. The retention becomes actually workable for every institution. So it is very essential for everyone of us. Patient safety improves with the remote monitoring by virtual nurses. Early detection of significant changes in the patient's condition allows for their timely interventions. Virtual nurses collaboration with the bedside nurses to ensure medication safety. Whenever there is a new medication which is prescribed to the patient, there are so many doubts about it. One particular doubt is always for every patient. Morning dose, I have missed. Should I take 2 tablets at a time? That query is always there because they are not from medical background. They are not so literate, so they have this query. So what is very important is actually advice for taking medications, which becomes easy with the virtual nursing program. Patient's experience improves as they connect with the virtual nurses easily through the device. We have discussed about it. So it is transforming healthcare through the technology. So now the healthcare facility, healthcare system is improving with the technology which is available for every nurse and nursing professionals. It enables quick access to nursing experts without physical presence. You are not required actually to be there with the patient at the bedside or at the door, and vice versa. But actually virtual nurses can provide accurate information, accurate advice, a concerned advice to particular patient. Bedside nurses can focus on critical tasks while virtual nurses manage admission, discharge, and patient's education. So virtual nurses can take care of these aspects where bedside nurses can focus on clinical patients and provide the best of the clinical care to patients, right? Streamline workflow enhances efficiency in the patient care. So when everybody knows their task in the healthcare system, then work is already streamlined. So everybody knows actually what is my responsibility in the healthcare setup. So then there is no mixing, there is no interfering of one another's work, and that is why actually everything actually runs smoothly. Okay, risk of using virtual nursing in patient communication, privacy and data security, we have discussed about, lack of personal interaction. When virtual nursing has come into the picture, there is no human touch. We have talked actually earlier in the chatbot as well. Technology may help us accurately, but then there is always missing one aspect which is very essential, and is the human touch. So here also, uncertainty, lack of personal interaction, technical issues. Sometimes actually it is very difficult to get connected to the person because of the network issue, maybe because of the financial constraints. So that is not available for every person. Those who can afford it, they will have this access. Otherwise, actually it becomes technical issue. Limited physical. So here actually this helps in the physical setups. So limited physical setups and physical assessments becomes difficult with the virtual nursing. Legal and ethical concerns. Some of the areas where actually it has to be avoided, but since it is available, everybody uses it, and so actually ethical concerns where there is something which need to be avoided is provided by this way. And then cost and implementation charges. Of course, as I say, every one of us cannot afford to have this virtual nursing or virtual nurses. We cannot afford it, and that is the reason actually cost-wise it becomes barrier for us. Risk of miscommunication, technical delays or unclear video, audio can lead to the misunderstanding, and that is how actually this person who is available online and is not able to get access to the person, or there is a communication gap, or there is no clear actually technical support, then it becomes a barrier for everyone to get advantage of it. In conclusion, chatbots and virtual nursing technologies are transforming healthcare by improving the accessibility, efficiency, and patients' engagement. Right? While they cannot replace the empathy and the critical thinking of the human nurses, they serve as valuable tools for supporting the clinical decisions, providing the patient education, and offering the round-the-clock assistance to the patients. Yeah, the future of nursing care lies in the balance, integration of the human compassion and the digital innovation. So this is how actually, though the technology has come up, though the technology has made our life and patients' life very easy and comfortable, as well as say, still human touch is very essential. If you touch the patients, we always say that. सगळे डॉक्टर ॲक्च्युली कोणतेही डॉक्टर बघितले आपण तर ते मेडिसिन सेवन देतात बरोबर. परंतु असे काही डॉक्टर आपले असतात की ज्यांनी आपल्या डोक्यावर हात ठेवला मला काय झालं असं म्हटलं तरी आपल्याला अर्ध बरं झाल्यासारखं वाटतं. काय हातामध्ये मेडिसिन असतं भेटलं, but we have faith in person, and that is the reason actually touch is very important. Touch of the God and touch of the healthcare workers is equally essential. Thank you so much for being here.
Thank you so much, sir, for the interactive session. You really captured all our attention, giving us lively examples throughout the session. Once again, I thank you so much for being with us and gracing us with your presence, sir. I request Professor Nirmal Mohan, sir, to present the certificate and memento as a token of love and gratitude to Professor Samuel E. Fernandez, Principal at Jalgaon College of Nursing and Research Institute, Nashik. Is Madam with us? Okay, so we had the question that how do you ensure a patient's data remains confidential during a teleconsultation? I repeat, how do you ensure patient's data remains confidential during a teleconsultation? And she has given us the answer that this can be done by following encrypted messaging systems. Only the authorized person can access it. That is, only sender or receiver can see the message or data which is shared. So by this we can keep it confidential. Whatever teleconsultation is done online, we can keep it confidential. So this is the answer given by her through WhatsApp. I hope the answer is clear for everyone. Okay. So moving forward. Education breeds confidence, confidence breeds hope, and hope breeds peace. Moving forward to our next session of the day, the e-paper presentation and evaluation. Because of large number of participants, we had already started the session in the morning, 9:30 a.m. We had almost 36 participants. So Group A was started already, and Group B will be conducted through the Zoom platform here. So I request Professor Jacinta Ma'am, Vice Principal of Godavari College of Nursing, to lead us through the online session.
Good morning everyone. I am welcoming you all to our online paper presentation. I am Professor Jacinta and today we have our evaluators Dr. Lalisa Fernandez, Professor Adi Moolam, Professor Ashwini Vaidya, Professor Manorama Kashyap, Professor Meena Devi and Professor Hemant Kishore today along with me for this session. We have a fantastic lineup of presenters and I am here to ensure everything runs smoothly. As you heard before, that today we are having 38 presentations and the presentations has been divided into two groups. Group A presentation has commenced at 9:30 a.m. on separate Zoom link and still is going on. Now we are going to start with the presentation of the Group B. Before I begin, I like to go over some important instructions for our presenters and our audience. For our presenters, please ensure that your microphone and camera are functioning properly. Make sure you are in a quiet, well-lit space to minimize any distractions. When it's your turn to present, I will prompt you to share your screen. Please have your presentation ready to share and ensure that it is full screen mode for a better visibility. Each presentation will last about 5 minutes, followed by a question and answer session of 2 minutes. Please be mindful of your time so that we can accommodate all the presenters. We will hold questions until the end of each presentation. For our audience members, please use the chat function to submit any questions during the presentation. If you experience any technical difficulties, feel free to message us directly in the chat box and our technical team will do their best to assist you. We ask that everyone stays muted during presentation to minimize the background noise. Thank you. And one more thing I want to say, today we are going to award 2 best papers. The 2 best papers will be awarded. The first place with the cash prize of rupees 6,000 and the second place with the cash prize of rupees 4,000. award is sponsored and brought to you by SR Health Edu Academy. This SR Health Edu Academy is devoted to promoting excellence in nursing research, clinical skill development and innovation, empowering faculty and students to contribute meaningfully to healthcare advancement. So, I wish you everyone all the best. Please be ready with your slides. We will start now. The first presenter is Ms. Vidyapati Devi Kongam. Ma'am, are you ready?
Oh, yes, ma'am.
Yes, ma'am. You can share your screen now. Start your presentation. We have a time constraint of 5 minutes.
Yes, ma'am. Ma'am, I'm unable to share my slide, ma'am. That's why it's taking time. Yes, ma'am, I'm doing it again, because I'm never to share my slide.
Okay, ma'am, I'm calling for the second participant. Ms. Beulah, ma'am, are you ready?
Ma'am, hello?
Hello? Hello? Is it possible now? Is it audible to you? Hello? Hello? Hello?
Ms. Beulah, ma'am?
Yes, ma'am.
Ma'am, can you please stand now?
I am trying to see now.
Yes, ma'am. Beulah, ma'am, you can present.
I am from Anna.
Renugala ma'am, are you ready?
Ma'am, shall I send you my PPT to your partner to be published separately now?
Okay ma'am, you can send the link.
My last time.
Konka Vidyapati ma'am, your slides are visible. Your screen is visible. You can present.
Good morning, everyone. Good morning everyone. My name is Godavari. I am based scholar at Western University, and today the topic is study practice of the knowledge of parties among the model children with regard to the research incident in selected area and improvement credits. The objective of the study are to improve knowledge among the model target 5 children with regard to the prevention of incident. Second objective is to assess practice among the mother of under 5 children with regard to the prevention of accident. To analyze the relationship between the knowledge among the mother of under 5 children with regard to the prevention of accident and selected variable. And fourth objective is to analyze the relationship between the practice among the mother of under 5 children with regard to the prevention of accident and selected variables. And the fifth one is to determine the relationship between the knowledge and practice among the mother of under 5 children with regard to the prevention of accidents with the selected variables. And the methodology of object for the study is descriptive study design, and population accessible population is number of under 5 children, and the sampling technique is confidence sampling technique. The sample size of the study is 150 mothers of under 5 children, and the inclusive criteria include those who are under 5 mothers for the study in the program and typical elementary ability, able to understand, read and write and do, available at the time of the calculations, and willing to participate in the study. And exclusive criteria include not residing in the family group, not physically and mentally healthy, able to understand, read and write and do, and not willing to participate in the study, not at the time of the convention. The analysis and interpretations are given in the 5 sections. The second one is the characteristics and listen to analysis of the knowledge and practice among the model of under 5 children with regard to the prevention of accidents. Section 3 include the analysis of the relationship between the knowledge among the model of under 5 children with regard to the prevention of accidents and the selected variables. Section 4 include the analysis of the relationship between the practice among the model of under 5 children with regard to the prevention of accidents and the selected variables. Section 4 include the analysis of the relationship between knowledge and the practice among the model of under 5 children with regard to the prevention of accidents. And the analysis of the second section 1 it shows the characteristics including the age of the mothers. So around 46 of the mothers are below 20 years, 16 mothers are below 25 years, 30 mothers are below 26 to 30 years, 4 mothers 31 to 55 years of age group, and 2 are above the 25 years of age group. All coming to the educations, 20 of the mothers are non-literate, 123 mothers are first to 10th standard, and 4 are intermediates, and 2 are in graduations, and 1 one is forced regulations and the other. And occupations of the mothers included 24 hours housewife and working mothers are 156. And on coming to the income, 44 mothers are listed 5,000 per month, and this is 5,001 to 10,000 per month, and 7 are 10,000 to 10,000 per month, and 3 are more than 10,001 per month. On coming to the religions, 50 are Hindu, 32 mothers are Christian, 16 mothers are Muslim, and 2 are in other specific. And the family includes 55 are nuclear, 58 are joint family, and 7 are extended family. On coming to the social provisions, 48 are from religions, and 80 are from the health personnel, and 20 are from the magazine, and 2 are from the magazines, and 20 are from the other social. And the types of the houses include 13 are the house, and then 18 are from the job house. And the number of other participants, 14 are they have only one child, and the 25 mothers they have 2 children, 10 mothers they have 3 children, and 1 are more than 3 and 5 children. On coming to the section 2, analysis of knowledge in the practice, more than one of the children with regard to the predictions of the accidents. It shows the analysis of knowledge because that the majority of the mothers, for 54% that inadequate knowledge, while 39.3% possess moderately educated, and only 6.6% that educated knowledge, with a mean score of 82.16 and a mean percentage of 54%. On coming to the practice, the findings shows that most of the mothers, 55.3% demonstrated moderate practice, 8% were educated, and 56.6% were inadequate practice, with a mean score of 80.6 and a mean percentage of 51.3%. Significant associations was found between the knowledge and the academy and between the practice, the education level, and the product and the parenting, emphasizing the existence of the knowledge practice care. On coming to section 3, analysis of the relationship between knowledge among mothers and men with regard to prevention of accidents and the collective variables. The findings reveal that knowledge can communicate associations with the types of the family, and indicating that the mothers from the joint families tend to have better knowledge, and there is no significant associations was observed between the knowledge and other variables such as age, education status, occupation, monthly income, number of the participants, types of the house, or source of information. On coming to section 4, analysis of the relationship between the practice among the mothers and the participants with regard to prevention of accidents and collective variables. The study found significantly significant associations between practice and education sector, as well as between the practice and the number of other participants. There is no significant associations for between practice and the variables such as age, occupations, and track, money income, type of the house, or the sources of the information. On coming to the section 5, the analysis of the relationship between the knowledge and practice among the mother and the participant with regard to the prevention of accident. There is a positive correlation between the knowledge and practice among the mother and the participant regarding the accident prevention and getting very higher knowledge level or generally associated with the better preventive practices. On coming to the conclusion and the finding, most of the other mothers have inadequate knowledge but moderate practices. It shows superior knowledge practice get changed, and there is a need of the structural teachings and community awareness to improve the mental safety and the behavior. And there is a significant association between the family tax and education, and 54% of the mothers show inadequate knowledge, while 55% and 50 the moderate effective practice. So I have concluded my topic presentations.
Thank you for your presentation. And now it's time for question and answer session. You are leaders can ask the questions now.
How do you assess your practice of among mothers prevention of accidents?
For practice, I have prepared a checklist. In that checklist, there are one questions that we have distributed, and that checklist assessing the practice in median and the solid emission score. This topic actually is dedicated for the prevention of accidents among the home care management. And in the community health care, most of the rural and the near-urban area is more benefit because accidents are more identified. So we can give awareness and good counseling and any model or any technique to prevent these types of the accidental injuries.
What was the most surprising result of your study?
In this studies, I have found out that the knowledge and the practice well. So we can rectify this knowledge and practice by the improvement of the knowledge and the practice well. Like most of the mother, they have the some knowledge, but they have been practice, but they don't have the adequate knowledge. So this data I have found in my study.
Hello ma'am, one more question. What limitation did you face in conducting this study? What limitation did you face in conducting this study?
Actually, many of the mothers, they are not properly clear about what they are doing. While taking care of this accidental injuries when caring of the child. This type of the difficulties when I was interviewing or I was actually this from the mother side.
Thank you, ma'am. Thank you for your presentation. Now, I would like to call upon Ms. Beulah Mrs. Ma'am for her presentation. The slides will be shared from our end, ma'am.
Okay, ma'am. Good morning everyone. I am Jila, Professor of Experience University of Manila, Professor College Nursing, and also University of See, my research out here is studying to assess next slide now. A scientific to assess the effectiveness of IIT that is opinion indicator. However, a reduction of residual levels on other filter type 2 diabetes filter in selected areas of IIT. Next slide. So, overview of the research study. Diabetes mellitus is a small metabolic disorder. It acts by elevated residual levels due to lipid secretion, enzyme action on it. Hyperdiabetes mellitus above the majority of the diabetes and it's a main tropical factor. IBGAM is known as the main senior because it's common found in the tropical regions. It has been traditionally used for its anti-diabetic properties. It leads to a diuretic hormone that makes it regulate blood glucose levels that impacts insulin sensitivity and metabolism. Next slide, coming to objects. So first objective is to assess the peaks and doses level, first fasting blood glucose level among others with type 2 diabetes members, next standard and control. And second one is to assess the peaks and doses level of growth transient blood glucose among others with type 2 diabetes members, next standard and control. Third one is to evaluate the effectiveness of antibiotic program on reduction of blood glucose level among others with type 2 diabetes members, next standard and control. And fourth one is manual application will be treated level of post-target residues among others with the type 2 diabetes members with the directly responsible variable in experiment and in another. Next slide, hypothesis. Next slide. I show us there will be significant difference between the mean weakness and in extremal and control group. Actually, yes, there will be significant difference in the need, weight, and dosage develop. Food not being able to go from a direct to the crisis damage members making a direct control group. And actually, yes, there will be significant association between meat induced level of post quantum glucose on a type 2 diabetes method, experimental and control group. And exposure, there will be a significant association between the post level of and post quantum glucose level on another type 2 diabetes method with the right development variable in experimental and control group. Next, coming to the research methodology. Next slide, ma'am. So, research methodology. For monitoring research both and two extreme methodology and process development variable for the study. The study is measuring 4 areas of mechanism between maybe Jalgaon, Jalgaon, Rama, Malapur, and Additional Knowledge. Jalgaon has to discover stable type 2 diabetes method others totally, and in Malapur has typically type 2 diabetes method others, and in Rama has 37 type 2 diabetes method others, and Malapur has the coordinate people with the type 2 diabetes method others. Among the 4 areas, Malapur and Malapur and for extremal group, and Malapur and Rama group for control group. Next, coming to the data collection tools. Section A is number tables, includes all A2 sites, using individual tables, population, monthly income, from dietary, healthy lifestyle practices, conventional practices, among them, not voting on the right. Family use of diabetes methods, duration of diabetes methods. And section B is the recording of costing and postponing the report level, includes cases and orders, costing and postponing the report. And the first day of previous was done as investigator, and 28 days post was done. And the whole procedure is, next slide now. Scoring was measured by using artificial active residue glucometer that consists of 4 levels of residue levels. So the coffee residue is 280 for coffee, and for most of the coffee there is the property into the field. And any averages there is 1 to 126 kg per year for coffee, and 4 for beer carrying average 140 to 250 per year. And for average coffee residue that is greater than 133 kg per year, and for both for beer average is greater than 250 per year. And the description of the data collection. So next slide now. Description of the data collection. Result quantification of the ideology folder. So you will prefer accidentally the factor control ideology. So you see the quantification are removed from the ideology by manually. Leave the right nicely another convey and share what you need. The package is always then total form of tax is separately. So the step 2 is next slide now. Step 2 is admission of ideology folder. So administering 1 gram of ideology folder to the subject for every day. They are connected 4 areas to the study. The first way is to get the ideology folder that is put on to all the people. Then they are actively the ideology folder with the help of water, which is stomach area to 9 area in the increase stomach in the distribution of the investigator. Then investigator are doing the common transfer of fat as we go into folder package we want to receive. Then they will be gone out, they will be beyond the water whether they are consuming or not. Next is the test. Next is the test. Next is like action of ideology folder. So it has active. So it active instinct and active instinct like glucose phosphate, lactate, and then it is controlling the hyperglycemia and the diabetes. So it also contains beta protein, so it is a way to bring the results from the plant fiber. So that's also includes also protein and fiber. Next, coming to the data analysis. So we are considering right now. Considering the distribution and the education services, frequency percentage distribution working to accommodate the demographic and medical variables among others to the capital method. Here as a distribution of the effectiveness of and courses development. Developers level and because presentation advocacy from both the developers level is better developing and making images sound analysis like you mentioned. Then coming to the definition of development areas, the experimental group and another group. So each mentioned university figure category working with qualities to divide into divide. And experimental working is working and the text naturally and experimental group. And the region and the education credit education everyone for the group and another group. And coming to the occupation, considering all the next slide. Coming to the occupation, you are educated, unemployed, government employee, and resident employee, and also next slide one. All that the figures taken on the group and group. You are given the vacancy and the percentage. And the next slide. About family continuing from your necessary management factors for family. And the next slide, narrative pattern, tells the liability, lifestyle practices, and the lifestyle practices. And coming to the description, here you will be giving the activity, coming here, practice better, and do it from the practice better. So coming to the data, this is slide 1. Coming to the data, assessment of level of loss in the group on analysis type of damage centers, the experimental group study and control group study, the previous frequency level and percentage and previous frequency level percentage. Here is the parameters where the previous is 40 and the total is 9 and the control group the previous is 40 and the total is 60. Coming to the next slide, So